It's a pleasure to see you all here. I'm Jeremy Tavaret. I'm the Pro-Vice Chancellor of the Faculty of Health and Life Science. And it's a great pleasure to introduce Lucy to you. But first of all, it's a massive pleasure for me to be able to introduce Lucy and actually introduce our inaugural lecturers. There are two incredible rites of passage in an academic life. One happens behind me when I'm able to award degrees to our undergraduate and postgraduate students as they wander across the stage with a big beaming smile on their face. It's an enormous honor. And my other greatest honor in my career and my job is to introduce the inaugural lecturers and also to be able to see the incredible quality of the people who are promoted to professor at the University of Bristol. Sitting on promotions committee, which I actually don't do in my current role, but I did do in my previous role. And it's just an enormous privilege to see what people get up to, the incredible work they do, the incredible teaching they do, civic engagement, that brings to this, them to this position in their lives. So congratulations to Lucy. It's an absolute pleasure to welcome Lucy's mum and brother and lots of other members of the family, and actually lots of friends of Lucy's, I think, as well in the audience, and many other members of the public, because it is a public lecture. So welcome to the University of Bristol for this lecture. It's a pleasure to see you. So Lucy is a professor of palliative and end-of-life care here at the University of Bristol. She's a research leader recognized internationally for her work on serious illness and bereavement. And in Bristol, she leads the Palliative and End-of-Life Care Research Group and co-directs the Centre for Grief Research and Engagement. She's also the co-director of the new End-of-Life Matters Health Integration Team at Bristol Health Partners, which is an organisation that connects the two universities in Bristol and our NHS trusts and our community partners. It's a very important connecting piece of infrastructure. So, Lucy, thank you for doing that for us. However, I'm going to now introduce you to Fliss Murtagh, who's director of the Wolfson Palliative Care Research Centre at Hull York Medical School, who's going to tell you a little bit more about Lucy.
It's an absolute delight to be here with you all today. And it's a real honour, Lucy, that you've asked me to say a few words to introduce Lucy's inaugural lecture. So Lucy and I met over 20 years ago. We met when Lucy came to King's College London, where I was working at the time. And there were a number of things that struck me, which I'm going to share with you. 3 things. The first thing is what struck me within a few months of working with Lucy. And that was the quality and the depth of her thinking. It was different from many others in the team. And I think, Lucy, it was because of your grounding in philosophy, that you brought that quality of thinking to your research that has stood you in really good stead all the way till today and beyond. So that was the first thing that really struck me. The second thing I have seen emerge over the last years, I've been honoured to sort of kind of be in a mentoring role with Lucy, although sometimes I wonder who's mentoring who. But it has been wonderful to see the depth and the range of research that she uses to bring a voice to the people who don't get heard. And that's been in your bereavement work, and it's also been in, for example, the coastal communities work, and in many other aspects of your research. And to bring a voice to the people who are not heard is a rare and important quality in this world. So compliments to you, Lucy. And the third thing that I would also say, as I look back over the 20 years that I've known Lucy in her research, She brings an extraordinary balance of kindness and rigour. And that is wonderful for the team that she works with, but also the people that she's trying to develop herself. And that is something I think several people in the audience will have experienced, and it is a wonderful quality that I hope you never lose sight of. And those three things, I think, have brought you to this place, and I think will take you forward in your programme of work. So it is a real pleasure to welcome you to your inaugural lecture.
Thank you so much, and thank you for the kind introduction, Fliss. So, welcome, and thank you very much for coming. In this lecture, I want to tell you a bit about myself, about the journey I've been on, the things that have shaped who I've become, and that are important for where I will go. I would like to start, though, by inviting you to jump in at the deep end and take part in an exercise with me. So let's start with the deep breath. And please close your eyes if that's comfortable for you. I would like you to imagine that you're going to see a bereaved parent, a friend or a neighbour, whose 5-year-old has suddenly died. You're waiting outside their house before you ring the bell. And you haven't seen them since their loss. Take a few moments here. Consider what is going through your mind. What would you be thinking? And what would you be feeling? So coming back to yourself now, back to the room. I'd be grateful if you would remember and file away the most prominent thoughts and feelings in those moments, because we're going to come back to this situation later. For every single one of you, the scenario you just experienced was unique. It's not an easy thing to imagine, and you may have found it difficult or uncomfortable, and certainly not a feeling that you would seek out. My research looks at what is often considered a really uncomfortable topic in our society. We usually shy away from thinking about death. We avoid planning for the end of our lives, and we see death and dying as the remit of professionals. In many ways, we're also made to feel that we should hide our experiences of illness and of loss. In our society, aging and illness are themselves somewhat shameful. We feel that we must not deteriorate, that we must not be a burden, that most dreaded of things, to be in need of support. With the successes of modern medicine, we've lost our everyday familiarity with death and loss. Unlike in previous times where deaths occurred at home and in the community, nowadays in the UK, most deaths occur in a hospital or a care home. And our lack of familiarity with death and dying can breed fear. And that fear has consequences for our health system and for ourselves. So in the health system, we over-medicalize death and dying. We avoid conversations about the end of life, and we sometimes continue pursuing curative treatment when it's no longer beneficial to do so, as shown in this cartoon. And then, when someone is grieving, we may let our worry about saying the wrong thing overpower us. And so we don't say anything at all, leaving bereaved people isolated. In a 2022 survey, a clear majority of bereaved people said their community had not helped them deal with their grief. Nearly a third said they didn't have access to the right bereavement support, and a similar proportion said they'd experienced people not acknowledging their loss at all. Because we don't talk much about what grief is, When it happens to us, its nature and its power take us by surprise. And my career so far has been spent exploring aspects of these issues. So what it means to live with serious illness, what it means to grieve, and what support might help. In preparing for this lecture, I've had to reflect on why I've devoted my career to this subject, which lots of people might think is just a bit morbid. And it starts with these hippie lovebirds. That's my mum, Mary, who's sitting here in the front row, and my dad, Barry. Our family was a meeting of cultures, working class, middle class, British, Mediterranean. My mother is half Italian. My dad was a gifted translator, and his work took them to Europe. So I was born in Sweden. I moved to England when I was 2, and then to Luxembourg at age 9, where I went to European school until I was 18. For me, it was a gift to be exposed to such a rich diversity of cultures and languages. I had friends in Luxembourg who claimed to dream in 3 languages, and certainly they could swear in 3 languages. And in that environment, I became fascinated by the differences between cultures, between the things that can be expressed in one language or culture, but not in another. At the school I attended, each nationality had a dedicated section, so the classic stereotypes were very much on display. So the biggest drinkers, the Brits and the Danes, the loudest, the Italians. But once you got to know people, the categories faded and the individuals came into focus. And at the same time, my own categorization became somewhat complicated because I felt British, but to my cousins in the UK, I wasn't. So I was between 2 worlds. That feeling of being unmoored was still new to me when, aged 10, I encountered something far more disorienting, and then my father became ill. So this is my father, Barry, years earlier, with me as a baby. You can see where I got my hair. Over 5 years, his health rose and fell, and at times he was seriously ill and in hospital for treatment. Those were difficult years for my family, but something made it uniquely different for my younger sister and me, because we were never told exactly what was wrong or what might happen next. Now, Barry died when I was 15 on Christmas Eve, and I later found out he had multiple myeloma, a rare blood cancer. There was no palliative care team involved in his care and no one to support him or my mum in how to talk to us kids about his illness. Here he is, as I remember him most, lying on the bed, reading the newspaper. So what did I learn from this early experience of loss? I saw firsthand that love and a desire to protect can translate into silence, anxiety, and disconnection. That grief itself is not simply sadness, but a profound estrangement from the ordinary flow of life. I felt like I'd been thrown off the merry-go-round, and I had no idea how to get back on. So when it comes to my education, people assume that as a professor of palliative and end-of-life care, I must have a medical background. I don't. So at school, I liked both science and the arts, so I loved English and I also loved biology. I enjoyed thinking and writing about big questions and topics, and I initially planned to study biology, but after a year out, I changed my mind and I opted to study philosophy. First at Nottingham and then at Birkbeck. So at Birkbeck, my philosopher and supervisor was the amazing Miranda Fricker, who at the time was developing the concept of epistemic injustice. It asks who gets heard, who gets believed, how credibility is assigned, and how all of this is shaped by discrimination and social injustice. My MPhil thesis was on the nature of objectivity in science, arguing that the very nature of science makes diversity among its contributors essential. So science, in many ways, is social, so it's shaped by assumptions, values, and images through which people interpret the world. And because those assumptions can include prejudices and blind spots, objectivity depends on scrutiny from a range of perspectives. Inclusivity makes science more rigorous and more robust. I'm sure my dissertation never reached a 3-figure readership, but that early thinking still shaped my belief that research is best done in teams where diverse views are encouraged. Besides teaching me to think analytically and conceptually, studying philosophy also helped me express myself precisely, which has proved very useful. After my MPhil, though, I realized I didn't want to be an academic philosopher and discovered that there was no stampede of employers desperate to hire someone with 2 philosophy degrees. So I found myself rather rudderless and struggling to find a job. So I went with the current, and entirely by chance, I landed a temp job at Help the Hospices, which is now called Hospice UK. So working there, as surrounded by people interested and dedicated to end-of-life care, I found myself drawn to palliative care and the philosophy of palliative care. So for those of you who aren't sure, palliative care is an approach that focuses on improving quality of life for adults and children facing life-limiting illness and supporting their families. So it's holistic, and it seeks to prevent and relieve suffering by addressing physical, psychological, social, and spiritual needs. And it can be provided alongside other treatments. So after a year at Help the Hospices, I took a huge leap into the unknown. So in my mid-20s, I decided to go to India to study yoga. At the same time, I wanted to work, and I recognized that I needed to work to get some experience. And through my volunteering with the Tropical Health and Education Trust, I'd become increasingly interested in research. So as luck would have it, Professor David Clark, who was then leading the International Observatory on End-of-Life Care, was about to start a review of palliative care in India. And somehow I arranged to work on the project as a field worker, traveling around the country, interviewing key people. I was given a printed list of names of people to contact all over India with phone numbers and email addresses, and off I went. So you can picture me turning up to interview you, backpack on, mini disc recorder in my hand, looking really only marginally more professional than a gap year student who's taken a wrong turn. I traveled all over India, so it was my first research job, and I was really kind of in at the deep end. I visited over 50 different palliative care centres and hospitals around the country, and I conducted interviews with professional staff, volunteers, patients, and family members. I met so many inspiring people across that beautiful country, most of whom were driven by personal commitment and a belief in providing the best possible care in difficult circumstances. So in Kerala, for example, I met Suresh Kumar, who's seen here. So he's one of the pioneers of the state's public health approach to palliative care, who helped spread the specialty across Kerala and beyond. And Libby Salno, who's now head of department at UCL, who I still have cups of tea with today. So in Kerala, care is community-owned and community-driven. So it's built around the strengths and resources that already exist within the community. And I saw the power of that public health approach firsthand. So even bus drivers entering the bus station contributed 2 rupees per bus per day to fund the palliative care movement. So my time in India resulted in my first scientific paper as co-author, and also attending my first conference in Assam, where all the international delegates were assigned a bodyguard, and here I am with my bodyguard. At the end of my Indian odyssey, after all the interviews, yoga, meditation, I was sitting on this beach in Thailand, and I had a profound realization: damn it, I need another job. So in what now looks suspiciously like the stars aligning, I came across an advert for a researcher position in the Department of Palliative Care, Policy and Rehabilitation at King's College London. And I started as a research associate there in July 2005, and that's really where my career officially began. So I worked at King's for over 10 years, mainly under Richard Harding, who's now Executive Dean, doing research on some of the more neglected aspects of palliative care. We were based in Denmark Hill, South London, first in the Western Education Centre, and then at the beautiful purpose-built Cicely Saunders Institute round the corner. At King's, I trained in social science and was exposed to a huge amount of methodological expertise and learning. It was an exciting, demanding time, and I threw myself into it. I worked on many different studies, which led to 65 journal papers and 80 conference presentations. I went back and had a look at my CV. I know you'd love to hear about all of those in great detail, but time forbids. So instead, I've opted for an academic version of Desert Island Discs. So the first study I worked on involved interviews with palliative care and cardiology clinicians, patients and family members to inform the development of a heart failure palliative care service at St Thomas's Hospital. A key finding was that although patients expected honest discussions about disease progression, clinicians were unwilling to disclose poor prognosis because of their own discomfort with talking about end-of-life issues. As a result, patients were unaware of their full treatment options, uninformed about the future, and often fearful and anxious. Preparing this lecture, I realized I've been grappling with variations on this issue ever since. We then went on to conduct the Encompass study, which validated the first questionnaire to assess palliative care needs and outcomes in Africa, the African Palliative Outcome Scale. I'm really grateful to Richard Harding for the many opportunities that he gave me. I was the first researcher that he had managed, and he seemed to have unending confidence in me. Well, he must have done, because 10 months after starting, he had me training 7 Encompass researchers in Cape Town without him. Here we are with the wider team from South Africa and Uganda. Being thrown in at the deep end, again, forced me to grow and taught me that in challenging environments, you need to build trust quickly and bring people with you. At the same time, I pursued my own research interests, traveling back to India with the Winston Churchill Fellowship in 2007 to explore how palliative care services there integrated yoga and meditation and patient and family support. This led to a growing interest in the existential aspects of the illness experience, which was ultimately the subject of my PhD. My thesis explored the assessment of spiritual well-being in sub-Saharan Africa via a systematic review of measures and mixed methods research. A key finding was that feeling at peace and having a sense of meaning in life were more important to patients than physical function or physical comfort, with spiritual well-being correlated most highly with quality of life. The research highlighted the importance of attending to psychological and spiritual aspects of care, as well as pain and other symptoms. Throughout this work, I was acutely aware of my own privileged position, my distance from the research setting, and the heart-wrenching reality behind the data, and I tried to work with the sensitivity that deserved. With additional funding from the Sahali Stewart Trust, I held several stakeholder events, and we produced spiritual care recommendations with a foreword by Desmond Tutu. I worked with colleagues across Europe and further afield to establish research priorities in spiritual care, and in 2012 was awarded the European Association for Palliative Care Early Researcher Award. Unfortunately, this also meant I had to present my first plenary to about 2,000 people in Trondheim, which was completely terrifying at the time. So as a postdoc, I then worked on the Top Care randomized control trial of a nurse-led palliative care intervention for adults with HIV, with Richard and PhD candidate Kira Lowther. So the trial found that the palliative care intervention did not significantly reduce pain, which was the primary outcome, but it did improve psychological quality of life, reduce psychiatric morbidity, enhance ability to share feelings, and support the family to plan for the future. The qualitative component of the trial was hugely important, showing that in this stigmatized group, taking part in trial data collection and being treated with compassion by the research team had itself benefited mental health and self-esteem in both the intervention and control groups. So as a visiting scholar in San Francisco for a year in 2013, I delivered research for the International Access, Rights and Empowerment Project led by Irene Higginson, a multi-country study involving post-bereavement surveys and hospital-based ethnography in the US, England, and Ireland. So in the ethnography, we found that across the sites, clinicians' poor communication and information provision, combined with routinized and fragmented inpatient care, restricted patients' self-belief, the self-management of their illness, their choices, and their decision-making. I remember an experienced social worker describing situations where patients had a load of complex information dumped on them and then were left to make decisions on their own, really just in the name of patient autonomy. So through this work, I developed expertise in what good end-of-life care looks like in different cultural contexts and settings, and how societal values, including the values of medicine, affect experiences of end-of-life and bereavement. In 2015, I then won funding from Health Education South London for my first project as principal investigator, transforming end-of-life care. So this study was about how to spread palliative care out of specialist provision and really start educating non-specialist palliative care providers. It resulted in systematic review and several papers with Lisa Brighton, which went on to directly inform my later work. So undoubtedly, a highlight of my time at King's was working with colleagues including Peter Speck, who's here today, Fliss Murta, Jonathan Kaufman, Catherine Bristow, and Barbara Gomez, and many others. Irene Higginson, head of department, demonstrated what it took to drive forward research in a field and build a genuine centre of excellence. I also learned what kind of researcher I wanted to be, and in 2016, after nearly 11 years at the Cicely Saunders Institute, it was time to spread my wings. So I made the big move to Bristol, coming to work here as a research fellow in what was then Bristol Randomised Controlled Trial Collaboration, now the BTC, based in Canning Hall. Building on my experience working on the Top Care trial, I developed my expertise in integrating qualitative methods within trials and worked on a range of studies with colleagues Jeremy Horwood, Athene Lane, and others. It was another time of rapid personal and professional growth. My new environment forced me to reach out and collaborate widely, an element of my job which I really love. I soon met colleagues Lucy Pocock, a GP, and Charlotte Chamberlain, a palliative medicine doctor, who's also here today. And we started talking about forming a research group in palliative and end-of-life care. Around this time, I was hugely inspired by a presentation by Dr. Becky Barnes about conversation analysis. So conversation analysis is a powerful, fine-grained method to analyze and understand video and audio data. It focuses on understanding and analyzing real-life communication, and it provides detailed, direct investigation of verbal and non-verbal interaction. So it allows us to study ordinary interaction and make those tacit communication practices explicit. So the detailed transcript, which you can see here, is used as a starting point for then analysing what happens next in conversations. Around this time, I was also introduced to Fergus Caskey, Professor of Renal Medicine, and I will always be really grateful to Fergus for helping to arrange funding via the UK Renal Registry to work up with what would be my successful application for a National Institute of Health Research Career Development Fellowship. So my fellowship brought together many of my passions, I suppose: improving medical culture, starting conversations about the end of life earlier, and equipping non-specialists with palliative care skills. So I designed and led the OSCAR study, which stands for Optimizing Staff-Patient Communication in Advanced Renal Disease. And during the study, we used mixed methods, especially ethnography and conversation analysis, and we collaborated with clinicians and educators to develop a communication training intervention, a package called Talk CKD Options, which equips kidney doctors and nurses with the knowledge and skills to support older people with kidney disease who are deciding what treatment to have. Researcher Ryan Sowden, who I'm delighted is also here, collected a huge amount of data, including 110 video recorded outpatient consultations, like this one on the left, which we analysed and then used in the training. The image on the right is a slide from the training that we've developed. I've been really lucky to work with a fantastic team on the OSCAR study, and we've started publishing from the study, and we finished piloting last year. So to stretch my desert island discs analogy, the career-focused story here sounds pretty positive because I've been playing all of the hits. But in the midst of those career highlights, something devastating happened in my personal life. So halfway through my fellowship application process, our second daughter, Ada Mary, was stillborn at 6 months. So her due date 3 months later was the precise day that the fellowship interviews were being held in Leeds. So I was faced with a really difficult decision of whether to continue with the process or to opt out. So much work had gone into my application that I decided to continue, and I'm glad that I did, but it was one of the most difficult periods of my life. Losing a baby is a traumatic thing to happen, as I'm sure everybody can appreciate. And while we'll never know for sure why Ada died, it was clear that poor clinical practice had played a role. I faced my own sadness and my own regret, but also the more existential aspects of grief, which I was less aware of. The insecurity and worry associated with the crumbling of an imagined future, the rug being pulled out from our feet. I also experienced firsthand the lack of understanding and stigma associated with baby loss. So it being minimized as just one of those things that happens, and a lack of understanding of the emotional repercussions of a sudden death of any kind. I remember too how much I appreciated those people who reached out and tried to connect. So one of the lessons for me was really how relationships sustain you when the worst happens. So there I am after this traumatic experience and doing my fellowship interview in Leeds. I think it was something like the 14th of July. And then 3 days later, I discover I'm pregnant again. So I delayed the start of my fellowship until I came back from maternity leave. So here's our third daughter, Eden, whose arrival brought us enormous joy. Now, when I was on maternity leave, still grieving Ada's death and reflecting on how we handle grief as a society, I came up with the idea for a festival about grief, and I started putting together a funding application to the Wellcome Trust and reaching out to collaborators. So through Jimmy Hay, a friend and film scholar here at Bristol, I was introduced to Liesl Dawson in the English department, who became an important long-term collaborator and friend. And when I came back to work after maternity leave in November 2019, I started my fellowship, but we also started planning the festival in earnest. So bringing together contacts across sectors and organisations in Bristol, we developed plans for Good Grief Bristol to be held over a week in May 2020. And then the pandemic struck and everything changed. So we cancelled our plans for the festival. And like many people, I started a different type of life that included, amongst other things, a lot of baking, making jam, homeschooling, and seeing friends and family only on Zoom. So in the summer, we put our heads together, and then working with event producer Aisling Mustan, we moved the festival online, recognizing that the event was actually needed now more than ever. And we held the festival in October 2020, on the eve of the second full national lockdown. And here you can see us behind the scenes with Liesl in the green screen room. We didn't just do everything on Zoom then, so it was a slightly different setup. So from the start, the festival had a strong focus on collaboration, equity, inclusion, and diversity. The program was really ambitious. It featured interviews, panel discussions, workshops, and webinars over 3 days. The response to the festival was much bigger than we could have anticipated, with around 6,000 people attending and international media interest. The audience engagement and feedback was almost overwhelming and made the hard work worthwhile. So here's just a small selection of some of the social media comments. We conducted a mixed methods evaluation, including focus groups to inform our future work. And nearly 3 years later, I eventually got round to publishing the pre-post survey findings. So almost 90% rated the festival excellent or very good, and 3 in 4 people said that through attending, they had felt more confident talking about grief, which of course was music to my ears. So as many of you will remember, in 2020, research studies were largely paused if they weren't focused on COVID-19, and that was the case for my fellowship study as well. So given my own recent experiences, when the pandemic arrived in the UK, I immediately thought about everyone facing bereavement in such difficult circumstances, and I launched into a number of literature reviews and exploratory studies to inform end-of-life care and bereavement support. That also included my first paper collaborating with my brother Dan, who's a software engineer, and helped with an analysis of Twitter data. I also, this time, made contact with Emily Harrop at the Marie Curie Research Centre in Cardiff, and we published a systematic review with her team, which looked at how we could take what we knew from previous natural disasters to inform a pandemic response to bereavement. Emily invited me to co-lead a funding application to the Economic and Social Research Council for a mixed methods national study of bereavement during the pandemic. The project ran from July 2020 to January 2023 and followed over 700 bereaved people over time, as well as gathering the views of bereavement support providers. And we've published widely on this work, helping to ensure that the voices of people bereaved during the pandemic were heard and the impact on bereavement services understood. So just to flag some key findings. First of all, in one analysis, we looked at identifying factors associated with the development of prolonged grief disorder. And these included loneliness and social isolation in early bereavement and lower levels of social support over time. Qualitative findings described in acute detail the extensive, multifaceted difficulties of being bereaved during the pandemic and the ways in which the people coped. Bereavement services pivoted quickly to providing support via telephone or internet, but inequities in access persisted and in some cases worsened during the pandemic. Half of the bereavement services we surveyed said there were minoritized ethnic communities who were not accessing their services. The study did, I think, make a unique contribution to the pandemic evidence base. We gave over 40 invited talks for health and bereavement professionals throughout the study, and the media took a great interest in our findings. In 2021, Marie Curie spearheaded the formation of the UK Commission on Bereavement, with Emily and I joining the steering group. The Commission published its landmark report, Bereavement is Everyone's Business, in autumn 2022, informed by our work, and in 2023, the project was shortlisted for a Policy Impact Award from the Economic and Social Research Council. The same year, my husband and I were invited to Buckingham Palace garden party in recognition of my work supporting bereaved people. And I know what you're wondering, and here it is. Delicious. And here we are with my hat. So this busy time bore many fruits. With sponsorship, we ran 2 more online Good Grief festivals in 2021, and we've continued every year since, offering webinars, workshops, courses, and a YouTube channel. I was invited to write an essay for the BMJ about grief during the pandemic. It blows my mind that this article has now been accessed over 21,000 times, which I strongly believe is at least in part due to my brilliant husband's help with the title featured here on the cover. In it, I argued that denying grief, hiding it away, hiving it off to a personal self, distinct from the professional, is to deny its place in life and to deny our humanity. Being open about our own experiences of grief and showing the strength of vulnerability is a powerful statement to patients, carers, and colleagues that can help shift society's attitude to grief. I believe that now more than ever. I also led exploratory studies working with researcher Ollie Claburn and funded by the National Lottery Foundation, shining a light on underserved communities and co-production methods, which were still relatively new in end-of-life care research, and in which participants are partners in developing the research and services, not just simply subjects. With the Subco Trust and Compassion in Dying, we explored the co-production of advanced care planning workshops in South Asian communities. And with the Abeli Initiative, we conducted a study exploring Black Caribbean communities' experiences of end-of-life care and bereavement. The Commission's work during the pandemic and our regular meetings with the Department of Health and Social Care also led to a commissioned NIHR call for research to tackle inequities in bereavement support for non-white British communities. And I was delighted to join the resulting Equitable Bereavement Care for All study, led by Sabrina Bajwa and Katrina Mayland. So this qualitative study recruited 120 people from ethnically diverse communities across England, as well as 23 bereavement support providers. And we're currently writing up this study with outputs to be published later this year. And we launched a short film about the findings via Good Grief Festival in December. So after all this activity, where did I find myself in 2022? Through these years focusing on bereavement and on Good Grief Festival, I've become increasingly interested in community-based, non-clinical research, not instead of my clinical research, but as an important complement to it. As I argued in this later essay, access to services and interventions is necessary, but it's nowhere near enough. The death, dying, caregiving, and bereavement are fundamentally communal events and need to be reclaimed as such. And this transformation requires more than investment. It demands a shift from needs assessment and service provision to genuine cross-sector partnerships. So Weston-super-Mare, where I'd been living since 2016, offered a chance to put this thinking into practice closer to home. I knew the town, its people, the social fabric, and I could see both the richness of its community connections and also the health inequalities running through them. With funding from the Arts and Humanities Research Council, I led a project to establish a community network there. The Weston-super-Mare Community Network for Health Inequities is an incredible group of about 130 people now from across different sectors, committed to coming together to make change happen. Together with researcher Alice Malpass, who's also here somewhere, we conducted innovative digital mapping work alongside stakeholder interviews. So you can think of this as drawing a treasure map of the town, so charting the hidden gems of community support, the types and levels of social capital, and how people might fall between the cracks. That work paved the way for a multi-site interdisciplinary study, the Coastal Community and Creative Health Project, which I co-lead with Dr. Barbara Mezes at the University of Liverpool. This involved 31 co-applicants from across different sectors and over 60 partner organisations from 3 underserved coastal areas, Blackpool, Hastings and Weston-super-Mare. So we're focusing in this project on 3 different topics: young people's mental health and well-being, substance use and serious illness and bereavement. And through the project, we hope to generate evidence and resources to reduce inequalities in these areas by enhancing and widening access to community assets. The team includes 18 community co-researchers embedded in the 3 communities, and the project is highly participatory, using creative methods to enable people to express their experiences, ideas, challenges, and resilience. In workshops with young people, people in recovery from substance use, and bereaved people, we've explored their use of community assets, the idea of belonging, and how we include and exclude people, often unintentionally. Here you can see some images from our workshops and the week-long exhibition which we held at Western Museum last summer. Through this work, I'm learning a huge amount from inspiring colleagues in the voluntary and community sector about the real meaning of collaboration and the power of diverse research methods. So we're about halfway through the project, a little more than halfway through, and I look forward to sharing our findings with you in future. Through this Arts and Humanities Research Council funding, we've also brought Good Grief Festival into people's communities in person, which felt like a significant milestone. So starting in 2023 with Good Grief Western, we ran another festival in 2024. So at the end of April, we're holding our next online festival, so you can go to the website and have a look at that. And after that, we have 3 more in-person festivals in the pipeline for this year, led and produced by local partners, in Hastings in May, and in Blackpool and in Weston in October this year. So we're coming closer to the recent past. So where am I now? In 2024, Liesl and I launched Good Grief Festival as a community interest company with fantastic support from Rachel Hare, thank you. And in 2025, we realised our vision of creating the Bristol Centre for Grief Research and Engagement at the university, with seed funding from the Integrated Care Board. And we held launch events in Bristol and Westminster. The centre will act as an umbrella for our research on bereavement at Bristol, which spans many faculties and departments. The Palliative and End-of-Life Care Research Group has grown, and my colleagues in the group are a joy to work with. We're all busy with new projects and plans, and it feels like a dynamic and exciting time for the group. So some reflections. I'm extremely lucky to work in a field which is so rewarding and in which I've been able to follow very varied interests over the years. In writing this lecture, I realised how often I've stepped into unfamiliar territory without quite knowing where it would lead. And I've also realised that I'm fairly comfortable being between worlds, which makes risk easier to tolerate. I owe much of that to my parents, who gave me the confidence to venture out and the reassurance that I had somewhere to return to. So thank you, Mary. My career has been anything but a straight line. I've veered off course and I've changed direction more than once. I hope that's some reassurance to anyone here who worries that they don't quite fit the conventional academic mould. There is space for many different kinds of academics. Building capacity and supporting others is a major part of our role and the part that brings me into contact with the most brilliant people. Thank you to all the researchers and PhD students I've had the pleasure of working with so far, particularly current researchers in the group, Chloe Shaw, Alice Malpass, and Jenny Birchall. And I have to add Ryan to that as well, because she's here and she did such a fantastic job on the Oscar study. I'd also like to thank all of those who've supported my career, inspired or influenced me along the way. This is my hall of gratitude, although inevitably there will be many people who are missing, so my apologies for that. And of course, I also owe a huge amount to my family. So our amazing children, Hazel and Eden, who keep me going and remind me of what's important in life, and my husband, Sean, who has held the fort on more than one occasion so that I could put in the time and effort needed to establish my career. So before we end, I would like to take you back to the beginning. So please take a breath and come back to your friend whose child has died, and how you would feel with your finger inches from their doorbell. I invited you to imagine that because that was me a couple of months ago. I felt unsure, anxious, and vulnerable. Would I say the wrong thing? Would she want me there? Would I cry? Would she cry? All these things went through my head. Despite all the theory and the research and my own lived experience too, it was hard, but I rang the bell. We all face moments like this where the easier thing would be to pull away, to tell ourselves we don't want to intrude, that someone else will step in. But you make the call and you ring the bell because leaning in, not pulling away, is exactly what people need from us. You need to feel the discomfort, to feel it, and if you possibly can, stay with it, rather than retreat into role, expertise, or self-protection. And you need to listen to those who are dying, caregiving, or bereaved. We should look to them for their strength and what they can teach us, not fear them for showing us how cruel life can be. From a professional standpoint, we need to do research which tackles inequity and prioritizes relationships. We need to advocate for better funding and access to appropriate support for everyone who needs it. We need to make policymakers listen. In clinical practice, staying with discomfort means acknowledging that both you and the patient or the family member in front of you are human and vulnerable, and that sometimes it's okay to say you don't know. It means being brave and learning how to have conversations about the end of life and the grief that goes with it. All of that, the research, the advocacy, the clinical honesty, matters enormously. But underneath it all, holding it together is something more fundamental. In the end, in both my life and my work, I've come to realize that human connection is where everything important starts and ends, and that if you let it, if you provide space, community steps in. So I'd like to end with a short film about Good Grief Western Festival. So this was made by Paul Collins, who's a local filmmaker, and I think it captures some of the spirit of the festival.
Grief can be a bridge between each other, between us and our dead. We will not forget them, and we will not be forgotten.
We talk about how there's this taboo about death and dying and grief and bereavement, but the reality is when you provide people with the opportunity to reflect and talk and learn and think about these subjects, there's a huge amount of interest there. The aim of Good Grief Western was to bring grief out into the open, encourage people to maybe be a little bit more open in how they talk about their feelings around grief and loss, and provide opportunities for people to learn and talk about grief and to engage with it in lots of different ways. In curating the programme, we really tried to reflect the diversity of people's experiences of grief. So we tried to include interactive events, arts and kind of hands-on crafts events.
I think it's finding what works for you as an individual, and for me it's art and it's creative things. For someone else it might be something different.
We don't all use words, so to be able to make something and express something in a different way, I think is a nice outlet for people.
It helped me deal with some grief of a loss of my dad in November last year, which brought up some grief for the loss of my twin sister when I was born. It's been very therapeutic.
But also events are focused on music and theatre and panel discussions. Our music events were really important, kind of bringing people in and showing people that through music you can get in touch with your emotions in a different way. When someone does experience a bereavement, they can be really surprised at just the extent of their emotions and the depth of their emotion. It can have an impact on your self-esteem, it can change the way you feel about yourself, it can change the way you feel about your life. It can really be transformative. We brought together people from the community across Weston, people working for voluntary and community organisations and health and social care, plus academics from the University of Bristol, to talk about the assets and strengths in Weston, as well as what we can all do to improve things.
Without grief, there is no joy, no connection, no freedom from the isolation of our individuality. Without loss, we pass through life empty-handed, not shedding, but not receiving either. We grieve, not just because we shed so much as we move through this life, but because we are connected to each other through threads of the heart. We are each other.
That's it. Thank you all so much for coming.
Hello everybody, I'm Liesl Dawson. I'm an Associate Professor in Literature and Culture, and I also work with Lucy on the Good Grief Festival and the Bristol Centre for Grief Research and Engagement. And it's my real pleasure to say a few words as we close Lucy Selman's wonderful inaugural lecture. First of all, thank you, Lucy, for such a fascinating and deeply moving talk, which captured not only the depth and range of your expertise, but also the personal commitment that drives your work. Lucy's work spans multiple fields and reaches across continents, improving medical culture and opening up conversations about the end of life. Anyone who has worked with Lucy will attest not only to her fierce intellect and her extraordinary productivity, but also her warmth, compassion, and collegiality. Lucy's work demonstrates that serious illness and grief are painful but important aspects of human experience that need to be understood, respected, and supported. She has helped to create a kinder, more grief-aware society, and she thoroughly deserves the title of professor. We don't take questions in these lectures, but I hope you'll join us for a glass of wine, where we can gather together to continue the conversation and celebrate Lucy's fantastic achievements. Thank you, everyone. And congratulations, Lucy.